I think if there's one thing that is really important for young doctors coming to UK, which is based on my experience and some of the things I had, is that doctors new to UK must have a very comprehensive period of induction and support in UK. So that is induction and support to help them integrate into the National Health Service, but also to help them integrate into the local communities. Because in our time, when I came, we had what was called a period of clinical attachment or clinical observership. So you were attached and you didn't have any major responsibilities, but that was about a 4 week period when you learned. Now, as it has happened, as things have moved on, there are doctors who are coming from, say, India, coming from overseas, and within a day, they are expected to get into the NHS system and start delivering and start working. So we are trying to see how it's possible to have a comprehensive induction for at least a week, how it is possible that these doctors are provided with some mentors, people they can trust, and people they can work with. So support induction are very important to be able to help people. And actually, we are also looking to see how some of this induction and some of this knowledge could be delivered before the doctors actually come to UK. So I have a background of having contributed to regulation in general. The first one was the healthcare regulation. So that is the regulators that will inspect hospitals. And so I was asked by the Secretary of State at that time to help set up a body that would help regulate hospitals in UK. And they were going to call it Commission for Healthcare Audit and Inspection, CHAI. And my view was advising the Secretary of State at that time that regulation is not about inspection and audit, because we are not just inspectors. Regulation is about how you continually improve healthcare and you improve standards. And therefore, the name got changed to the Healthcare Commission because it was a caring commission. So when the Healthcare Commission was combined or merged to form health and social care together, then I moved over to the General Medical Council, which, as you know, is the regulatory body for doctors. And on the GMC, I served in a number of capacities, taking this same focus that we were looking how regulation could improve rather than just be sanctions and punishment. But there has been a huge uh, gap in terms of medical regulation like the GMC, that whereas healthcare regulation could focus on improvement, the GMC is governed by the 1983 Medical Act. And that doesn't sometimes allow them so much to focus on improvement, but there are going to be regulatory reforms which will help the GMC to move to a different focus. But on the GMC, we started the Quality and Diversity Committee, which I chaired. And two, three things we did was that we found that the number of panelists on the GMC that were on the panels looking at fitness to practice issues, there was hardly any BME doctors. It was less than 2%. So working with organizations, working with BAPIO, working with colleagues in the system, we set up a BME forum, which was an engagement mechanism between the GMC and senior BME organizations and doctors, all BME organizations in UK. And what we were trying to do was address some of these challenges. And one thing we did was that we made sure that the number of panelists increased within 18 months to 18% from 2%. So that was quite a big achievement. Because what we realized was that you have to look as if you are diverse and you have to be perceived also. And you don't get these perceptions if there are no BME faces on the panels. And the other thing on the GMC we did was that I obviously helped revise the good medical practice. but we also were going through a new period of revalidation. And one of the key things with revalidation was that we had some data which showed us that doctors who will not be revalidated in the first tranche, the first 100 doctors who may actually not be revalidated, it may turn out that all 100 of them are BME doctors. And we thought that was horrific and that was shocking. So we looked at what were the criteria that we could not assure ourselves that these criteria were free of racial bias. And if there were criteria within that revalidation that we could not assure that they would be free of racial bias, then we took them out from the revalidation. And the good thing was that when the first tranche of revalidation came 6 months post revalidation in 2013, then there was no disparity in the outcomes of those doctors who were deferred, as we called them at that time, or not deferred. There are two other areas in terms of equality which I may share with yourself. One is in relation to recognition. So we were talking about sanctions, and the other ones are in relation to recognition. And again, when I became the medical vice chair for ACEA, which is the Clinical Excellence Award System, these are hugely prestigious awards, and I sit on the main platinum committee now. Again, there was a very small group of BME doctors that actually got recognized. And we made sure that there was a greater number, both in terms of getting recognized and also making sure that the decision-making groups or the panels were diverse, and we had that diversity. And lately, 3 years back, I was appointed to the Honors Committee for Health. This is the committee that will give the honors. And again, we were facing the same challenges that the honors that were given to DME healthcare staff. There were a very small number. There were less than 3% BME doctors at that time, 3 years back, who were actually getting the award. And we've done a number of plans and programs to see how we could improve that. And then in 2022, the New Year's honors list that has come out in January, this is the most ever diverse list in the history of the honors. And it's really, the total BME workforce in the NHS is around 23, 24%, and 21% of these awards have gone to BME staff. So this is really, it's recognized as a great achievement, both within health and within those that give the awards.
Right now, we are currently still in the middle of the pandemic, and it has actually interrupted a lot of things for a lot of people in all walks of life. So, according to you, what are the main challenges that the post-COVID medical fraternity, be it like, the trainees or the students or the doctors, the educators, or even the patients can face right now post-COVID?
Yeah, I think you're so right, because COVID has had almost an unprecedented, devastating impact on communities. Now, the healthcare workforce, along with the social care workforce, have really gone out of their way, and they have risen to the challenge, and they have delivered, even though they were stretched. But the risk is, as you said, that what are the challenges? The risk is that as the nation recovers and the NHS resets, the risk is that this medical workforce, stretched already to the limit and working in an environment with workforce shortage, will really get stressed and will get burnt out. So if there was one thing we need to do, that is, how do we make sure that we try and address the workforce shortages, and how do we make sure that we can build support, we can build resilience, and we can build professionalism within our own workforce. I also chair a center it's called Center for Remediation Support and Professionalism. And what we have done over the COVID period was, because we couldn't do any teaching face to face, but we were running a huge series of webinars on support, building resilience, and professionalism. And we thought that we were able to help a number of doctors who were really stressed to the limit.